that's all. Otherwise, most of the points what she has mentioned are the same thing. I am also going to just show you quickly. And this is the awake proning. Little larger slide for you to see. So it's a self-proning, conscious, awake, non-intubated patient. This is the one word I think you have to add in your answer. It is a non-intubated patient with COVID ARDS that shown profound improvement in oxygenation, leading to delay and even avoiding intubation and invasive ventilation altogether. I think most of you would have had a very good, rich experience with the first and second waves when you were all posted in COVID wards to manage these patients. So the concept of awake proning came to avoid intubation as much as possible because the mortality was very heavy in those patients who required intubation and went on to mechanical ventilation on a ventilator. So as much as possible, physicians wanted to maintain the oxygenation by their own self-proning method. So the physiological benefits, this picture is very easy to draw in the exam also. So this is the normal patient lying on the back with the tummy on the front. So heart is here. You can see the basal alveoli are all telectatic, collapsed. And the blood vessels here at the base are more engorged. So as she rightly said, the basal portion has a rich blood supply but poor ventilation. So there is a VQ mismatch. So by proning, what do you achieve? You expand the alveoli on the dorsal aspect, and there is good perfusion also. So the ventilation perfusion gets very well matched and the oxygenation improves. So as simple as that. So this diagram I don't think is a very difficult one to draw. You can just put an oval and then put 2, 3 red lines and put one red big circle. And show the collapsed alveoli here and all expanded alveoli here. So this is how the improvement happens. It more uniform distribution of tidal volume and reducing the cyclical opening and closing, that is reduced atelectasis is there, and recruitment of areas where the lung has not been previously ventilated, so recruitment maneuver also happens, and increased homogeneity with a less compressed lung and increased blood supply. Higher density of blood supply makes the ventilation perfusion more equal, and the muscles of diaphragm are more uniform, producing a distribution of stress. And because of the proning, we get a better secretion of the, drainage of the secretions. So you have to follow the protocol requiring minimal manpower. It is a low cost, low risk, minimal manpower because patient himself or herself are going to adopt the position. So you don't require, whereas in an intubated ventilated patient, you require at least 4 to 5 people to turn the patient on, and you have all the disadvantages of the line coming off, the monitoring lines getting peeled off, the catheters coming off. All those problems are not there in this particular proning. So because the patient is awake, you can take care of all the IV lines, monitor leads, everything can be taken proper care of with the patient himself slowly turning on his tummy. And it can be done even outside the ICU. It can be done in the wards, and then it can be done in the ICU in the mild to moderate severe cases. And but just because, as he rightly said, you put the patient on prone, don't relax. Always watch out for the worsening of the patient's condition. And the steps, of course, this is something like a flow chart or algorithm which he mentioned. And the indications are normally when the respiratory rate goes up, we always calculated the respiratory to FiO2 ratio. That was the formula that we were using to institute early oxygenation in these patients. So patients on oxygen supplementation via nasal prongs, oxygen mask, whatever supplemental non-invasive ventilation supplements you are giving, that can be continued in prone position also. There is no need to disconnect them. And this is the same question that is asked in the article which he has prepared. Who can prone themselves? Conscious, cooperative, alert patients. And how to prone? Explain the procedure to the patient, get the consent, emphasize that they should lie in the position at least for minimum 30 to maximum 2 hours for a individual session. And in a day, maximum 5 to 6 hours of proning is very helpful. And in anxious patient, very minimal sedation, maximum 1 to 2 milligrams of midazolam, not to give more than that because of the fear of respiratory depression. And you have to monitor these vitals as she rightly said, and the duration or interval of monitoring should be 15 minutes for the first 30 minutes because some hemodynamic instability may happen when the patient goes into prone in these conditions. So you have to be very watchful. After that, 30 to 60 minutes interval till the entire duration of proning can be done. And patients should be able to communicate with the face mask. Sometimes they may not be able to talk and shout. So for any need, they should always have a calling bell to call the caregiver. And patients with protruding abdomen will need a special mattress and multiple pillows. And this is how the normal proning is done in these patients. The patient here you can see is having a CPAP machine probably. And this patient is not having even that, may be having only a nasal cannula. So this is how the proning is done. And because probably they don't have a protrudent abdomen, they are able to lie comfortably in this position. And here in this patient, you can see all the ECG monitors are put on the back. So whenever the patient is put in prone, don't put the ECG leads on the front. That will cause compression and sometimes injury also can happen. And contraindications, those in need of immediate intubation or a compromised airway, respiratory exhaustion, uncooperative patients, patients with sensorium not intact, hemodynamic instability, or patients with trauma or pregnancy or recent abdominal surgery, all these patients, of course, cannot be put into prone. And what is the duration? At least 120 minutes for one session, that is 2 hours, and average 5 to 6 hours per day. When do you stop that? When there is a sign of increased work of breathing, that is the respiratory rate going up, and the patient is using accessory muscles of respiration, or the oxygenation going down, or hemodynamic instability like drop in BP or arrhythmias. All these things are indications for dropping this. So this much if you write, it usually can be asked only as a short note question. So you can just pick up these points and write it faster in your theory exam. And what presentation Dr. Sushmita made is good enough for you to understand clearly the basics of that wake proning. Okay. Right.
Thank you, sir. Thank you, sir. Any doubts from the students?